Well, Ross, thank you for coming today, making the effort to come all the way down from Newcastle to take part in the college's oral history program. We're very grateful to you. Let's start at the beginning by talking about where you grew up and where you went to medical school.
Yeah, I grew up in Newcastle. My father was an orthopaedic surgeon, very publicly hospital committed. At a time when Newcastle Hospital was very much a centre of innovation and new ways of doing things. And that permeated my family. We grew up with the ethos of question everything, especially facts. So dinner table conversation in my family was very argumentative at times, or in a nice way. I went to school in Newcastle and then went to Sydney University for medical school. At that time, my dream was to become a rural and remote GP, and particularly in Indigenous health. I'd worked in that. I had a year off when I was halfway through medical school and worked in the outback of Queensland as a geologist's assistant, and that's where I saw my future. But regardless, a friend in England wrote to me and said, look, there are plenty of anaesthetic jobs over here, which would be useful for GP training, and it might help with your personal life crises, which I'm alluding to indirectly. And so I found myself in England sleeping on the floor of a dumpy flat in Shepherd's Bush, looking for jobs.
Okay, and jobs weren't difficult to find in London at that time?
No. So I registered with the locum agency, and in fact 2 days later they rang me back and offered me a job at Ealing Hospital in the emergency department just for a few nights. And I did that and spoke to one of the anaesthetists there. And they said, "Oh, do you want to come and do a locum as a SHO here for 3 weeks?" Which I did. And all of a sudden, it was a friendly department. It was supportive. There were some interesting people to work with. And as soon as I started doing the job, it just felt right. And I fell in love with it right from the word go.
So let's just set the stage for everybody watching. This is 40 odd years ago.
Yep.
Everything in anaesthetics was completely different to what it is now. It was like a pre-electronic age. All our anaesthetic machines had flow meters, and you could actually get a spanner out and make your machine better if it was broken.
Yeah.
But really, all of that history is well recorded. What we're going to talk today about is system changes, which are less frequently talked about and have been very much part of your career. So what were the things that happened to you when you were in England that really influenced what's happened for the rest of your life?
Yeah, so as I say, Ealing was a small hospital on the outskirts of London. It certainly wasn't one of the glamorous hospitals, and it was underfunded and all that, but it had the esprit de corps that sometimes those sorts of situations develop. And so I was working in intensive care and in anaesthetics on, I think, 1 in 3 weeks in intensive care. And a few things happened, 3 cardinal events that made me think that the way things were done had to change. And so to set the scene, as you may remember, intensive care in the early 80s, we'd got on top of ventilation, and it was becoming available, and inotropic support, and that was about it.
That's right.
And that meant that with the patients who were brain dead, they'd worked out how to deal with that problem and the definitions of brain death in Australia and Britain and in other countries. But the patient who was lingering, who was never going to make a functional or any sort of recovery, that was a difficult situation to deal with. I was particularly confronted by the inhumanity of that. And there was one patient in particular, a gentleman whose sister used to come in every day and sit by his bed, and this went on for a couple of weeks. And it was clear to everyone that he was never going to recover. But we didn't have any legal or moral framework for dealing with that. But it was clearly inhumane, and we just kept on going until something happened to actually end the patient's life. So that had me fired up as something that has to change. And then another night, we were called up to the gynecology ward with a cardiac arrest. And you'll remember that, you and I will remember that in those days, cardiac arrests were running up to the ward to start CPR and putting in lines and all this on someone who had already had a cardiac arrest. But the nurses had to wait for a cardiac arrest to occur. It sounds so stupid when we say that, doesn't it? You tell that to the young folks today, they just won't believe you. But anyway, one night we were called up to the gynae ward, and we were greeted at the entrance to the ward by the senior nurse, who was looking scared, not for the clinical situation, but because, as she said, I know it's not a cardiac arrest, but this patient's really sick and I just wanted to get help quickly. And she was scared that we would just lose our tempers and go off at her for daring to call the head of the intensive care registrar and the medical registrar when it wasn't actually a cardiac arrest. But it struck me, what a great idea, we should do that all the time. So I put that into the back of my head as something to come back to. And then the other thing, which led on to the perioperative service, or perioperative system and perioperative medicine, goes back to the days when having surgery was seen as a big deal, and you went into hospital 1 or 2 days beforehand to prepare in hospital. And certainly I, and I suspect you may have had the same experience, we were taught as junior doctors that you go and take a history from the patient with a blank sheet, and you would diagnose problems that had been poorly managed or could be managed better, but you would try and work out what could be done in the next 24 hours to improve the patient's health. And it required a lot of work on our part, but there was that frustration of not being able to do things and the patients being poorly prepared. And at the same time, from an organisational point of view, the patients would be up on the ward, and on the day of surgery, they would be given a pre-med because they're all very anxious. They'd be given a pre-med of omnipon and scopolamine, which the nurses had to coordinate, that it had to be given by injection, required 2 nurses to check it out of the safe, had to be given 1 hour before surgery, and coordinating that was a huge stress for the ward nurses. And then one day there was the aha moment at Ealing, as I say, an under-resourced hospital with a true Dunkirk spirit. And the hospital orderlies went on strike. And so the question became, how are we going to get the patients down to the operating theatres? Now, as it turned out, there was a wide corridor outside the operating theatres, and someone came up with the bright idea of, look, we'll come in early, we'll get all the patients for the day and park them in the corridor outside the operating theatres, and we'll put a couple of nurses out there to give all the pre-meds. And in fact, that day, things never worked better because we could duck out, we could see the patients later on the list that we probably saw the night before anyway, and check that they were still okay. The pre-meds were all given at the right time. It was easy to get the patients into the operating theatre, and operating theatres ran really well. And it was only for 1 day, but it gave me the idea we should do this all the time. That was the initial idea. And then and all these ideas evolved over the 3 years while I was training. And then indeed, why do they need to come into hospital the night before anyway? That if we'd seen them in a clinic and we had adequate preparation, we could just bring them into hospital direct on the day to a separate pre-operative area and get all the advantages and avoid 1 night in hospital. So
they were all such big ideas at the time. I mean, they sound like so obvious now, but I can remember at the time thinking that this was like, what are they thinking? How are we going to bring people in the day of surgery? So
it's so embarrassingly simple.
Yeah. So you came back to Australia, finished your training, and then got a consultant job, which is where you started to be able to do something. So the first changes you made were in intensive care, I think, with your care of dying patients. Let's talk about how you did some
so Ken and Jill and Howard Roby, another one, and the nurses, we had the same feelings about this whole thing with the patients who are going to die. And the Solicitor General made a statement at a conference that withdrawing treatment from patients may not be legal. And that had us a bit worried, and we thought, this is ridiculous. And we sat down and we developed a protocol for what we called, it was my label, active management of the dying patient. And we developed a protocol to make their dying as dignified and as comfortable as possible. And we presented that to the family, and the family agreed. But importantly, what we did was that, because we knew that we were on the edges of the law. And so we documented doing this with 30 patients, and then kept our records and then published that in the Medical Journal of Australia in a paper called Active Management of the Dying Patient. And you challenged the law to take action. And in fact, they were very happy. The health department was enormously happy that we were prepared to put our necks on the line. But it was a grey area of the law, so it was redefining practice. But it was an interesting exercise to go through.
So it has caught on as a concept. Yep. So the other really important change you made was the Met Call team, which is once again something which seems so obvious now, but it wasn't. So tell us about how that happened in the end.
Yeah, well, that was... and this is one where I got blindsided. I related my story to Ken Hillman and Jill and the nurses, and we agreed, let's just change the criteria for calling the cardiac arrest team. And it seems a simple thing to do, but we came up with different criteria. I simplistically just said, look, let's just relabel the team and say to the nurses, you can call us any time that you're really worried. Ken was more scientific and had more brains. And he said, no, we've got to come up with physiological criteria. And we argued about that for a few months. And eventually we compromised that we had the physiological criteria of the unstable or deteriorating airway, the respiratory status changing, the cardiac status, and we had blood pressure things. And we had some, based on some audit of unplanned admissions to ICU, we had some science behind that. We realised that we had to get the Division of Medicine on board, but one of the physicians, Gabriel Collis, said, this is clearly a good idea and we should support it, and we all breathed a sigh of relief.
And then let's get to perioperative medicine as well. So you also had the opportunity to change what was happening with patients coming into hospital on the day of surgery.
So we workshopped the idea of the what became the perioperative system for quite a while, and the idea of having pre-op clinics, of bringing people in on the day and how we would make that work. Workshopped it with Ken and with Sean Behan and with the other anaesthetists, Martin Lum, and really just talked it through a lot for quite a long time. And we presented our ideas, and then we did a back of the envelope calculation based on, and again we thought, now what percentage of patients could come in on the day of surgery, realistically? But we said 60%. And we did some back of the envelope calculations on the amount of money that could be saved if 60% of surgical patients came in on the day.
And you must have had to collect a great deal of data in a time before we had really great electronic resources for collecting data.
Well, I'd like to say that, but mostly it was just based on ideas. But we did, and particularly, if you like, wargaming the idea of bringing patients in on the day. That was a huge conceptual problem.
Hospitals were not set up for that sort of flow through.
No.
It completely changed the way that people had to work, who had to be there in the morning, and it changed the administrative staff as well. Now, you've talked a lot about how we shouldn't undervalue administrative staff.
Yep.
It really did increase the need for admin people.
Yep.
And that's not something doctors always accept easily.
No. It was, And when we're talking about admin people, we're talking about people right at the clinical coalface, and what I think we should call paraclinical staff.
Yes. Yeah.
So not the people in the head office or the big offices, but the ward clerks and people like that.
Public facing people.
Yeah, and you need lots of them. And a lot of the work that goes on in hospitals isn't particularly clinical stuff, but it's about just shifting information around. Even in the much more sophisticated information systems that we have now, it's still a lot of information processing.
And the other thing that you also concentrated on is how the patient felt about all this.
We did a survey of the patients on exit, and initially we're just going to say, would you have preferred to have come in on the morning or the day before or whatever, but we extended it to say on the morning or 3 hours before or 1 hour before your operation. And in fact, almost 50% said 1 hour before the operation.
Less agony.
Yes. So the patients were much more on board with it than we thought.
That's really interesting.
Yeah.
So this system, it all started in basically a little hospital, has now spread around the world. So how did it disseminate from there? What did you do?
Steve Fisher at Stanford and Barry Finnegan in Edmonton came up with pretty similar ideas about pre-op clinics at the same time, and Mike Roizen in Chicago. And so there are others coming up with the idea, but I think my vision was a bit more comprehensive than this much. We put together this book, which is ridiculously simplistic now. It's embarrassing how some of the things in there, but I published that in 1994, just after the ASA meeting, and distributed that freely, and of course wrote it up in the journal, although that took a little while. And then in Australia, the Commonwealth Government heard about what we were doing, and they set up a thing called the National Demonstration Hospitals Program, and that funded dissemination of the ideas. And I was invited to speak to lots of places. So 2004, I got an approach from high levels of the NHS to go over to England, and I did this sort of 2-week speaking tour around Britain, which was lots of fun. And talking about the ideas, and again you saw the early adopters, John Carlisle in Torquay, various others who really took off on it, and then advanced it further, and that led to, in Britain they formed the Pre-Op Association, which was nurses and doctors together, which of course was really suitable for the NHS. And then a few years after that, about 2010 I think, a group in the States started, Bobby Jean Schweitzer and others, with Sparky, the Society for Perioperative Assessment and Quality Improvement. And there have been other groups start in the States, but I think Sparky is becoming the preeminent perioperative medicine group in the States. And then in Australia, of course, having been settled with just the clinics and bring patients in on the day, once we had that platform, people got the idea that, hang on, you can do more than just assess the patients. You can actually get in there and improve them, or even come up with tailored treatments specifically around the surgical episode that may improve their preparation, their operative course and their recovery. And then some of the physicians got involved, and the whole business of prehabilitation and exercise and medical optimisation preoperatively, and immunonutrition and all those sorts of things took off.
And here we are now with the college finally having a new qualification in perioperative medicine, which is, I don't imagine where you saw that coming.
I certainly didn't see that coming.
So another thing that changed a lot during your career was medical evacuation, and that's something that you were peripherally involved in until it had a catastrophic impact on your life.
Well said. Yeah. During the 1980s, again you may remember, the use of helicopters in medicine really took off after the Vietnam War, particularly in the US. There had been a lot of medevac pilots trained. There were helicopters. Hospitals realised that, hey, having a helicopter is pretty good, glamour for the hospital. And so they were fitting out helicopters, and they were saying it's an intensive care unit in the sky. And you would see the videos of the helicopters, and I saw some of them, fitted out with all the equipment plugged into the helicopter. And so the helicopter was made to look like an intensive care unit. And you could put a patient in there and plug them into all the machines, just like plugging them into the intensive care unit. And the equipment was pretty heavy duty. But clinically, helicopters were being used more in a scoop and run, or in Australia, surf rescue, and so that sort of mode. And that was fine. But by the late 80s, there was a group of doctors, anaesthetists mainly, in Sydney, Richard Morris, Lewis Galeur, Ken Wishaw, Howard Roby, Blair Mumford came on board, some of the others, who said we can do better than this. The biggest breakthrough at that time, and it's Howard Roby, Ken Wishaw, Lewis and Blair Mumford, and particularly Blair, came up with the idea that rather than having all the equipment in the helicopter, you built the equipment, which of course was being miniaturised, around the patient, and not just plonk it on the stretcher, but actually put it into a rigid frame and then clip that frame onto the stretcher. So it was rigidly connected to the stretcher at a standard that aviation safety could tolerate. And so what they called the stretcher bridge. And it meant that you would have the patient on a stretcher with the monitoring all attached to them, and all you needed then was to hook up an oxygen outlet and a power supply. But I've always been frustrated that I don't think they've ever realised just what a breakthrough that was.
Yes.
To have patient-centred monitoring. And it was an incredible conceptual breakthrough.
So what prompted you to get into these helicopters?
Well, I mean, they were there doing it, and I thought, oh, this is pretty cool.
Looks like fun.
It looks like fun. I want to have a go as well. So I signed up and was working with CareFlight part-time. One day we went out and we had to do a what we call a stretcher winch routine once every 6 months, which involves coming in the helicopter, dropping down with the paramedic and the doctor, dropping down to pick up a patient, load them into a stretcher. We did it once, and then doing it again, and we'd sent the patient up, the paramedic went up, and then I was on my way up, and there was a short circuit in the winch motor which fired the cable cutter, which is a ballistic device that fires and cuts the cable in order to get the helicopter free if the load has got tangled on a tree or something. And of course I was the load, and I was hanging at the level of the helicopter, and the crewman was just turning me around to pull me into the helicopter when this happened. And I knew what had happened, and just realised I'm falling. So I had vertebrae, pelvis, bladder, liver, ribs, lung, shoulder, humerus, and something in my elbow. It's never quite, I have limited pronation in that elbow, in that arm. So.
That's an extraordinary injury to come back from, like mentally and physically.
Yeah. Well, I was in ICU for 2 weeks, ventilated, and I had 14 units of blood, and then 6 months in hospital with rehab and all that, and yeah, it certainly changed me. It was very stressful for my family. We had a 1-year-old child at the time. He'd just had his birthday. And Marion was down in Hobart visiting family, but I was already intubated by the time she got to Sydney and all that. But yeah, it was pretty tough. But anyway.
I mean, none of us can actually work out why our life takes various courses, but do you think that has impacted your career choices and your approach to patients?
Absolutely. Well, one, there was it's an incredibly validating thing to look death in the face and survive. and whether it's survivor guilt or something else, but you really feel someone has looked after you and you're on this earth for a purpose and you better live up to it. You better do it. There are times when I think it's probably increased my empathy for patients in some situations. It certainly taught me some things about the way hospitals work.
Yes.
And famously, the importance of the nurse in charge of the ward. But when I was a patient, I was surprised at how disempowered the charge nurses had become.
Okay.
And that interns would walk in and swan about, and physios would walk in and swan about, and I thought, no, and that's not the way it should be. And with medical students, I've always said, now when you go in, you introduce yourself to the nurse in charge, not to say, come follow me as my handmaiden.
And so now you have decided to retire from clinical practice and then leap straight into being Lord Mayor of Newcastle.
That's been a funny thing. I've always been involved in or interested in civic affairs. I grew up in Newcastle. It's my hometown. There were things going on in local government that a lot of people were unhappy about, and many people had approached me and said, we need someone else. And I tried changing things from the inside and by all the usual things, but eventually it got to the point where people said, look, you've actually got to put your hand up, and so I did. So it was a bit of a different end to my clinical. I decided last year was going to be my last year of clinical practice anyway. So, and I gave my last anaesthetic on the 14th of October last year, which was the anniversary of when I was dropped from the helicopter.
Oh my goodness, gosh.
Yeah.
That's a sentinel event. So, look, firstly, congratulations on an amazing career. I mean, you've had a huge impact, there's no doubt about it. And I'm very grateful to you for coming here today to talk to us and for sharing all of these sometimes quite difficult memories. So thank you.
Yeah, it's a real honour and a privilege to have done it. And it is amazing thinking about how lucky I've been to have been involved in the things that I have been. So,
thank you.